Hello, good evening, everybody. Welcome to the classroom. So today we'll be discussing about what next for an anesthetist. Yes, the lockdown is extended. It's till May 3rd, I believe. So we need to be prepared on these days how to handle our cases and what happens after the lockdown. We also need to know some information about how the experienced people who are already managed the COVID surge to manage these scenarios. So in that point, today we are getting Dr. Sergio Bergese from the New York City. Dr. Sergio Bergese is here. He has joined us. Let me introduce Dr. Sergio Bergese to you. Dr. Sergio Bergese is the Professor of Anesthesiology, Director of Outcome and Clinical Research in Perioperative Medicine, School of Medicine, Stony Brook University, New York. Welcome, Dr. Sergio Bergese.
Hello. Thank you.
Hello. Yeah, I can hear you. How are you?
Good. Anil.
Okay. How are things there?
Good. You were very quick yesterday getting me. So.
Okay. Okay. Just we are on live in the YouTube and Facebook. So a lot of our anesthetists all over the country are watching us. So with you, we have our panel of experts here. Let me introduce you to them. Dr. Anil Sharma, he's from Delhi. Hi, Dr. Anil. How are you doing? Yeah, I lost him. Yeah. Dr. Anil Sharma, he's from Delhi. Dr. Anil, welcome to the show.
Welcome all. Good evening, sir, and hi Ponniah, and welcome to all who have joined us today. And hope it's a good discussion. Thanks.
Yeah, Dr. Rakesh from AIMS, New Delhi. Dr. Rakesh, welcome to the show.
Very good evening, and very good evening to all the panelists and the viewers for this show.
Yeah.
Thank you, Dr. Ponniah, for
being
part of it.
Hi, good evening.
Dr. Manish here.
Hi, good evening.
Dr. Anil Parakh here.
Good evening, Dr. Ponniah.
Hey, Anil, how are you?
We are our own Prasanna here. Yeah. Hello, Dr. Prasanna. Okay. So we will first go to Dr. Sergio Bergese and then ask him about what is the situation actually there, how did they manage, so that he could give us some inputs, because we are not still seeing so many cases here in our practice in India. He's working in a center which is one of the hotspot of COVID. And let us go to him and ask him what is the situation there. Did they expect such a surge? When the surge came, how did they manage, especially in the operation room? Dr. Sergio Bergese.
Sure. Yeah, so we are learning as we go. And the situation, what happened here is the cases did rise very quickly. And we kind of were expecting that. So we took some measures where many people were deployed to do other things, different things that you do in a daily basis. We stop all the scheduled surgeries. We are not doing scheduled surgery. We are only doing emergencies and urgencies. And that's very much it from the point of view of the anesthesiologist. So the younger people or the people who have training in critical care, those people were deployed. We created a few more critical care beds. And then the more senior people like myself, we stay more on the daily operations of the ORs and what to do with that, as well as dictating some guidelines, so to speak, in a way. I was involved in the hospital guidelines on how to manage patients in the operating room according with the data we have. And the other thing was I did a couple of guidelines you will see it published soon for with some of the neurosurgeons on the management of the neurosurgical patient, mostly on the patient with stroke, and what to do with those patients and so on, because that's a concern. So basically, I'm not a critical care expert, as you know. I'm not a expert on COVID. So I have some information, some documents on what are the challenges that we have, so we can go into that later on. What are we, what are the problems that we have from the disease? I can also talk a little bit about how we done on the hospital side to reaccommodate bed and so on and so forth. So how we expanded from 1,200 bed to 20 to 2,500 bed, and then finally, what would be some safe approach on how to treat from the intubated point of view. So those are the 3 or 4 things that I can give you the insight. To be honest, this morning I was looking through the documents that we have, the documents that we produce, because Ponniah just texted me last night and say, can you do this? And I'm like, oh, I'm not sure that you want to without preparation, but I thought it was important to share my experience. But again, I just want to be sure that I tell you exactly where can I help you and where other places you probably should be looking from true experts. So one of my Indian colleagues is a true COVID expert in the ICU. So then after this, I can put you in touch with him. So Purvi can talk to you guys at some point about inside the ICU, which will be the area that I cannot give you many details.
Yeah. And Dr. Manish, you had a question to Dr. Sergio Bergese. Your mic is mute, Manish.
Okay, we have around 10,000 cases in India presently because of the lockdown, and the lockdown has been extended also. But when the lockdown is lifted, there is a possibility of a surge that, as you could see in US or New York. So, how do you advise us to prepare for those difficult times? Like, what are the precautions that we should take? What are the preparations we should make for the time when the surge will be there?
So the way we started was, the people who were tested, or there was not much testing in the US in the first place. So the few people that were tested, or the people who have symptoms. So when we started, we divided in what we call PUIs, patient under investigations, patient positive, and patients unlikely to be positive. So the unlikely to be positive, we treat those patients like, with full PPE, I mean, fully dressed, but nothing major, so to speak. And then the other 2, we put a little more care. But unfortunately, it happens to me, of course, as soon as this started, one of the first positive patients that we didn't know about it was my patient. So for instance, it was a neurosurgical patient. We put her to sleep, and then 2 week and a half week later, I get this phone call saying, well, by the way, your patient's ready to go home, and said, oh, my son had this pneumonia. I got to go help him out. Oh, wait a minute. So they tested, and we learned it was positive. So clearly, then you follow the process. Basically, what you do is you just, check your temperature, report the data, and so on and so forth to see, if there is any chance that you were positive. So, even I did not get tested at that point. I got tested later on. Now, to answer your question, Manish, specifically is at some point, you just gotta treat everybody else like they are positive. So I think you getting into that phase now. For instance, here in the New York, we treat everybody else like it's positive, right? And the other thing is we had specific guidelines for the practitioners, the physicians and nurses, that they are different than before. So when we started, I was in Germany, actually, and a friend of mine was in Italy. When we came back, he was in Italy. He had to spend 2 weeks on quarantine and so on and so forth. Now you don't do that anymore. So everybody else is considered to be exposed. In my department, 10 anesthesiologists were positive and exposed and have symptoms. And the rest of us, even if you are exposed, as long as you don't have fever, as long as you don't have symptoms, you just go to work. So you clearly, to answer Manish's question, is you get into this phase where you just have to go to work because they're going to need you more in India, which you guys are, for per number of patients, you guys are much less than we are here. So they're going to need you more. So basically, you just need to be in this second wave of considering everybody else is going to be positive, considering that your physicians are going to be exposed, considering that, unless they have symptoms, you're going to have to keep working. So basically, that was my answer to you.
Okay. Dr. Anil, you had a question to Dr. Sergio.
Sir, in the light of what you have told us, how you are working in the shifts, are they normal shifts or are they 12-hourly shifts? Secondly, whether the person who is working in COVID with a COVID positive patient, he stays in the hospital or goes home. Thirdly, what are the types of PP? Are you categorizing it to the need of the surgery, or you are issuing regular PPs to all the persons involved in the operation theater?
Right. So everybody else had PPE. I would say that in the news was a little bit that I heard that they were not enough, and sure, I think when I was exposed to this first patient that I told you early on, I did not have my N95. But since then, we all have PPE. So PPE here in my hospital, I'm going to speak just for my hospital because we are so busy that you don't have time to truly talk to other people. The PPE has not been a problem. So we had N95, we have plenty of it. We have face mask, and then the intubation team has full hoods and look like Martians, so to speak. And I have those too. The thing is, I have not had the opportunity to use my hoods yet because, again, what I do is not necessary yet. Now, to answer your question a little more in detail, what we did is, and I think you asked me this, is we divided teams early on. So the first thing that we did is we stopped surgery. All the people who were in the surgery center, so to speak, on day surgery got assigned to help critical care doctors on patients that are positive, that they were moved into the surgery center. Surgery center became an ICU, so to speak. The other thing that we did is we created early on intubation teams, right? So for instance, you get the people who are younger, the people who are healthier, or if you test the people that are positive, you put those people in your intubation team and you protect the older people, so to speak. So creating intubation teams give you, I think, two benefits. One is that you have these people that are pre-selected, so to speak, but also they always 100% dress, ready for this, and in a different location. So that way, a mistake is unlikely to occur because they're they're full dress. All they do is go intubate people. They may do 6, 7, 10, 12 intubations a day or 20, but it's good that, they just, you don't have to think about it. It's not going to be me to be called, what is my hood, what is my stuff, and so on and so forth. So that helped. Then we also got some rooms in the hospital, and we asked for those rooms. Got a cold room, we got a second cold room, people can sleep in there. Then we got a room where all the PPE are hanging and drying. And then we have another room where we have a, less invasive PPE, the spacesuit, but something more simple, blah, blah, blah. So all those kind of steps we done. For instance, we got a place where we can clean, so to speak, the N95. So every N95, you put your name on it with some numbers, and you can get it clean every day or whatever you need it. So those kind of things are the ones that help the most. That way, you know what you're going to encounter. So.
Okay. So that answers your question on how to go about with the shifts and how to allocate a team for a specific purpose. One question I wanted to ask you, Sergio, do you get a specific consent for COVID when you take up these patients to the operation theater, in the sense that you could become COVID positive later on, even if the even if you don't show symptoms now, or in the post-operative period, you could carry a COVID infection. You could get a COVID infection from one of the healthcare providers or in the hospital environment. Do you get a consent, a COVID separate consent?
So two things. The first thing that you said was the teams. That's very, very important. So the teams, you need to do it not only for the reason that I told you, but also to protect your people. I know Indians they're very strong and they think that they can work 25 hours a day, but the reality is you're gonna get tired. So you gotta be ahead of this and say, well, let me protect my people. I mean, you grabbed me yesterday. Yesterday and today were my first days off, so to speak, to catch up with my research. So it's really tiring. It's tiring because, the psychological pressure, you got to go there and get dressed every day. You can't answer the phone because your mask doesn't let you talk. It's hard to breathe. It's different. I mean, it's very, very different. I mean, if you eat and then you put your mask and your suit, oh God, I mean, it's just impossible. You just want to vomit it. So it's different. So you got to do the teams. It's very, very important. The second thing is trying to have a OR routine that is different. So people who are not needed, just take it out. Just if people don't need it, just let it get out of the room, and be sure. I mean, I had a document that I opened right here, which is isolation, so to speak, for the healthcare worker in the hospital. So it doesn't help that we do isolation and then we go to the hospital and it's 20 of us talking to each other. So that's very important that less people. In India is going to be difficult because you guys have much more people in the operating room than we do. We have much less. You cut that down and keep those people out. And the other thing is I get to the hospital, put a mask in my car, and I get my N95 in my other mask on top of my N95. There's a question in there we can reuse, and I'm going to answer in a minute. So put the mask on it, and you can be talking to your best friend, but you do it with your mask, and we keep the distance. So we don't, even though there is my colleague that I used to speak every day, walk into the room and sit in his office. Now it's different. I sit far away, or we speak from the door, but always with your gear on. So that's the way you handle it. I mean,
I was asking about the consent. Do you take a consent from the patient that he contract a COVID.
Yeah, I think all the rules as we know it, they are going to change. For instance, here in New York, lawsuits are on hold. So in theory, somebody else dies, something happened, cannot be sued, and So I'm not sure you can prevent that. We have not consented. I don't think it's practical. And furthermore, if the patient become positive, how do you know that patient become positive in the hospital, in their house? What are you going to do? You're going to do PCR to trying to match that virus. If it match the one in the hospital, it's going to be very expensive. So basically, the only thing that we do when we consent, let's say the patient had because of broken hip, or let's say something they can wait a little more. You tell them, that this is very possible that you're gonna get a problem here. So it's your choice to do this surgery or not. Let's say it's gonna do a cholecystectomy. Somebody else that is not acute, that is right there, and can you go home and wait and see it gets worse? I mean, you explain it to them, but beyond that, no more than that.
No more than that. Yeah.
Let me answer this question with somebody else on me here, so that way we get it out of the way. Is if he can reuse the N95.
Yes.
So the problem here is that I say yes, okay, you should, because I'm afraid that you're not going to have enough to throw it away every day. So if you look at 3M, the manufacturer basically said, well, this is made to be fed once and end of story. But unfortunately, there are not enough. So I think if you're careful and you wear that surgical mask on top, that's going to protect, it's going to be clean. You throw every time the other surgical mask to protect the N95. Now, if you intubate somebody else that you know is positive, probably then you should throw it away, or you should let it dry, or you should do something about it. You can do 2 or 3 things. If you get 3 N95s, you got 3 N95s, you use 1 each day, so they'll dry. So it will, because the virus will only last 48 hours, not 72 max. So if you use it 1 day, let it dry for 2 days, use it again. So if you can alternate those 3 masks, that would be a really good way to do it. So get 3 and do it this way. The other thing you can do is, some people are using UV light, but the problem with that is it may destroy the fiber. So I'm not sure about that. And now we got some kind of sterilization process the hospital got that I'm not sure what data is behind. So, but basically, I got a few N95s, and and you can feel it kind of, if it's sealed. If I can't breathe, it's because it's working. If I start to breathe better, it's time to throw it away and get a new one, basically. Again, one of the questions say right here, what about other areas of this hospital, blah, blah, blah. Well, it's the same story, right? So the problem is that if the virus gets stuck to outside of the mask and then you use it again, it doesn't matter where you wear, you're going to catch that. So I think the technique to get it out is very important. So you be sure that you don't touch your face at any moment, that you clean your hands at all times, that you have alcohol. Yeah, you get a process. So I have an alcohol in the door, I have an alcohol when I leave the PACU, I have an alcohol in my office, use it before, take my mask, use it again. Some people use like a Tupperware, plastic things that you put it on top of your mask and get it out, and then put it back on, so that way you don't touch your mask. I mean, that's the thing that you got to be more careful, not touching your face. Now, the other problem is in ISNAC, I think it needs to be fully aware of this, is that if hospital administrators do not have masks, they're going to tell you that it's okay to use it 100 years in a row. And I think here's the societies where they done is a little bit to put the stop to that and say, well, no, we sign up to help people out. We sign up to do this job, but we didn't sign up to do this without the proper tools. So one thing that as a society you got to be careful is that you support your physicians and be sure that the hospitals don't say things that are not true. So you got to balance in between. Well, ideally one every day, but if you use it for a week or 2, 3, if it is clean, it's fine, and so on and so forth. So one of the things here say, clarify when to reuse. Well, is Rakesh Garg asked me. So it's hard to answer that question, because if you look at 3M say use it, throw it away. After 8 hours, the filter start to go down. So that would be the ideal answer to that. But if you don't have enough, well, put a surgical mask on top and go from there. But again, you can put 1 surgical mask, 2, 20, I don't know. I mean, there's no data on that. So all I can tell you is what the manufacturers say, and then never been tested beyond that. So it's up to you to make a call. If I go and I intubate a patient that is positive and is coughing and so on and so forth, then I'll throw it away. No question.
Okay. Because okay, Dr. Bergese, at this point of time, what are the electives you are doing? How are you choosing your cases? Can you shed some light on that? Because now we are in a lockdown, the selective cases are less. But once the lockdown is over, or during this period itself, some semi-elective cases, urgent cases may come up. So how do we go about and select the patients? We are discussing about cholecystectomy and things like that. When it comes to neurological cases and cancer surgeries, especially, they say that all the cases has to be done at the earliest. So what are you actually doing there? How are you selecting your cases?
So all the elective surgeries are cancer. All the elective surgeries are cancer. So an acute cholecystectomy is different, because the patient can die if you don't treat it. So that's different. You got to do that. A broken bone, you got to do that. That's easy. So, surgeons always are, always a little more aggressive than we are. So, but I think the way we're doing it now is we all sit in the morning. I mean, the people who make decisions, one for anesthesia, one for surgery, and says, this case goes, this case doesn't go. So it's easy. Cancer is a very interesting question, because, are you willing to wait a certain amount of time and so on and so forth? So I think you got to make a judgment call. Just remember that the implications is not only the you're doing it or not. The implication is that you're taking a bed that you're going to need, that you're taking a vent potentially that you're going to need. So that's why you don't want to do it, because you don't know what that wave is going to come. So it's not only about getting infected the patient or whatever it is you are going to need that bed. You're going to need that ventilator, So yes, I mean, for instance, in New York, all the cancer surgeries, when the wave started, many of those surgeries were sent somewhere else. They were sent to places like Oklahoma or Nebraska, where they didn't have cases. So.
Okay. One question which everybody is interested is, do you routinely screen all the patients who are posted in the
yeah, that's a good question too. Yeah, that's a really good question. So I think so. So the answer is yes. I think at this point, most of the places, everybody else who's coming for this semi-urgent, not emergency, because emergency, but semi-urgent, are tested. So all these patients are tested. So at this point, what you're getting into a little bit. So yes, we are testing those patients. And here's somebody else, Anil, Sharma.
I just wanted to know, do you have all the hospital of a COVID hospital, or you have un-COVID patients also different hospital, dedicated hospital for not non-COVID or something like that?
Oh, every hospital is a COVID hospital, and again, not only every hospital, is that we have to double the beds. So we put beds in the stadium, we put beds in the parking lot,
Same applies for the obstetric patient, or you have dedicated the
Say it again, Anil.
Obstetric patients.
Yeah. So yeah, that's different. I'm not an obstetric expert by any means, but I was talking to the director of the obstetric, and it is my understanding. Don't quote me on this. It's my understanding that those patients are higher risk for aerosolization because it appears to be that when they push and so on, they aerosolize more. So in OB, I saw a picture yesterday actually of her that they are fully cape down, dressed with a complete thing because they treat those patients are positive. And for whatever reason, the percentage appears to be higher in the obstetric population, for what I understand. It's not my area. So
Okay.
their healthcare work is being regularly tested. Anil asked, and in some places they are. In my hospital, one of my colleagues is doing a research testing IgE and IgG and IgA, and that's how I got tested. So I'm not positive. So unfortunately, you want to.
One clarification I want to give to all the people, like you said rightly, sir, even if there is someone who is COVID positive but without symptoms, he is on duty, right? This is a very big thing, right, sir?
Correct.
And anaesthetist
I can read it to you. Yeah, I can read it to you. PPE for employee, it says, our current practice is to have distancing, separation for 6 feet. Employee must wear face mask when entering the hospital until they leave. PPE, distance, don't eat and drink, maintain social distance, so on and so forth. And yesterday, we got, I think this week, we got the new communication from the state who says, even if you're positive, if you're being exposed, as long as you don't have symptoms, you need to go to work. Yes.
Thank you, sir. This is important.
All right. So this answers the question. When we are using the routine PPEs as recommended, then there is no need to quarantine a whole hospital or the whole lot of healthcare workers or the units, even if they get accidentally exposed to the COVID positive patients. Dr. Bergese, to conclude your discussion, are you using remote monitoring in any way, or have your practice changed that each and every patient you have to go and see them personally, or your technology helping?
Yeah, so if you can, right. So there's a big effort here to do telemedicine, but that's not easy. You need certain things in place. So yes, the hospital has a huge telemedicine, giving privilege to everybody else to practice telemedicine, and that's what we're doing at this moment. I mean, not me personally, because I see patients go to the RST. But again, all the anesthesia, the problem with the anesthesiologist, I don't know if you guys seen it, but yesterday the Time magazine put an Italian anesthesiologist on the front page. Meaning, what you need to understand is that we are at a higher risk. If you look at, there's a multi-center, this is called aerosol generated procedures, which is done by Kai Tran. It shows the anesthesiologist intubate, the intubating person, I should say, not the anesthesiologist. The intubated person is 6.6 times, which much higher risk than any other thing. So clearly the anesthesiologist is a much, much higher risk, number one. Second, unfortunately, you are trained to do critical care work in a way. So you keep people alive every day. So you're going to be moved highly likely to a critical care unit. So you're going to be next to the COVID patient, exposed to the COVID patient. So telemedicine would not work for us. And isolating those people, I mean, what are you going to do? Stay out of your house for 3 or 4 months? I mean, I just don't see how that's going to happen. So basically what our guys are doing is just going to the COVID room, hanging all the stuff in there, taking a shower, getting new clothes, and then when you get home, hide at a corner and throw things there. I'm getting a shower every time that I get here. So leave and come back. That's the best thing you can do. Use soap, and soap will kill the virus. So, try to do it the best you can.
And one more question, Dr. Bergese.
You're going to get used to it, though. You're going to get used to it. So first, it's very scary, but then you're going to get used to, you're going to be more comfortable moving around, because then when you understand a little more, you're going to feel more comfortable. It become easier every day to move around.
Okay. About doing regional anesthesia and nerve block stuff. There are some guidelines which say that a full PP is not required in this scenario because there's not much of aerosol generation.
Yeah.
So
Well,
you agree with what is the protocol?
Yeah, we don't know that. So unfortunately, the 2-3 things that you don't know. So what I know is that people are aerosolized, number one. Second, this virus, third, we thought it was big and it's going to need a cough or some effort. Now appears to be that it's not true, and appears to be that normal breathing can transfer the virus a good distance. So number one. Number two is, so that aerosolization now become an I don't know, right? The other thing is, if you put a nasal cannula or you put a mask, the aerosolization become more, right? So when you put a nasal cannula, if you sedated that patient, now you're truly aerosolizing even more. And finally, the thing that concerns me the most is that most of the data with SARS and SARS-CoV-2 and COVID-19 data on aerosolization, it doesn't truly separate on how those things were done. So if you look at intubation being higher, I don't know if that intubation was done with people that were fully dressed, or what instrument they were used, do they know, and so on and so forth. So I don't know. So basically, for my readings and what I wrote with others on the guidelines for the treatment of stroke, is that probably intubation give you a certain degree of protection, because you full dress yourself and you intubate in a controlled situation, and then you put a filter and you connect that and you're done. Otherwise, then it's and if you got to assist that patient because it's not breathing well and so on and so forth, you're going to be continuously exposed. So I think at this point, our current recommendation is intubate as much as you can and seal that as much as you can, and then you're controlled. So
I would like to add one thing. This is a false sense of security that regional is better, or we require less PP because of two issues. One is the possibility of getting that surgery converted into general anesthesia. Now you cannot go out and then again don proper PP and come in, right? Another thing is the duration of contact, and you as an anesthetist standing on the head end, where the possibility of aerosol coming to you is much more. Even a slight cough can trigger these problems. So this is what I wanted to add. So this should not be a false sense of security that since I've given a regional, I should not have an N95 or a proper PPE, or should not have a face mask with a shield. I feel personally that we should have all the precautions that are necessary.
Okay, Dr. Anil, we'll come to that discussion later. To Dr. Bergese, what is the data? Because you said the healthcare professional, especially the anesthesiologist, when you are facing the intubation aerosol generation procedure, we have very high chance of contracting COVID. It's up to 6.6%. So what is the data now in your setup? Because it's been a surge for quite a few weeks. So are there any healthcare professionals, or especially anesthesiologists, who have contracted COVID when on duty?
Oh yeah, 12 in my department alone. 12 in my department alone. The person that I want you to talk, Purvi, which is the Indian anesthesiologist in charge of the ICU, that I can put you in touch to do it. He was one of the first ones who got symptoms. So he was at home for a week and then he got better. So yeah, absolutely. Now, do we know for sure where those 12 people got infected? I don't, you know. So people get infected. One of my really good friends from Spain, who is an expert on mechanical ventilation, which I wrote 2 or 3 papers with them, Javier Garcia, he got really sick. He was in the ICU until this week, and he was prone, and he went through the entire thing. He got really, really sick. So yes, people are going to get sick. That's no question.
So with this regard, I'll go to Dr. Rakesh Garg, who represent our ISA also. So ISA, Indian Society of Anesthesiologists, has brought out some practice advisory on concerning this also. They advise all the anesthesiologists to wear the N95 all the times. Dr. Rakesh, could you shed some light on that practice advisory, and we can discuss with Dr. Bergese on that? Yeah.
Right, sure. Now, when we're looking about the taking experience from various countries, the Indian scenario is a little different as of now. We are in stage 2, where the community transmission is not happening. And we had the time to have some preparation of arranging the things. So that was a little good aspect, that we can prepare ourselves, and the preparation is ongoing. So what the ISA advisory is already suggesting, that any person who is involved in the management of patient, whether emergency procedure or COVID patient, we expect that those should be wearing the proper protection devices, protective equipment should be worn by them. Now the point is, now what type of protective devices are to be ensured by those persons will depend upon the type of procedures being undertaken. So when we say the PPE kits, they will be having a level 1, level 2, and level 3, and that would depend upon the type of area which the healthcare worker is in the ICU, or the management inside a OT case where the patient is COVID positive. It will be that level 3, wherein starting from the headgear to the mask to the shield and everything should be worn in. But in those scenarios where the patient is being examined from some distance, like OPD areas, or walking across the hospital, it would be some suspects also, then just de-escalating a little bit of it would be appropriate, wherein the other precautions like using an N95 mask, a surgical gown, is definitely advisable for them. So this is what we are suggesting, so that we can use judicious use of PPE kit, which may become scarce at any moment of time.
Yes.
The ISA is supporting. Yeah.
No, what I was going to say is that, yes, I agree. The thing that you just got to think about it is we wear the N95 and the shield in the hospital. It doesn't matter where you go, you always have it. And then when you get into a patient area, then you put your gown and glove and so on and so forth.
Absolutely. Absolutely. So
what you got to remember, right? What you got to remember is that you don't want your healthcare worker to get infected. So you don't know where the hospital they're going to catch it. So if your healthcare worker get infected, then who's going to take care of the patient? So that's why you know, sure, you don't need to be walking around with a full, you know, astronaut suit, but the N95 probably at this point should wear it in the hospital.
And the other aspect, I think, if we see across India, the hospital, dedicated hospitals has been designated as COVID centers. Even in a hospital, a specific building, a specific area is being designated as a COVID center. So that's really helping, because the whole hospital will be a COVID center, and the government is earmarking them. So this will be advantageous to protect our healthcare worker, and the pooling of the healthcare resources will be another advantage for us. So that is what is going to have a good forward. And with regards to ISA is supporting, helping to procure those kits. They are financially supporting those persons who are not able to financially gain it. So there are representatives from ISA across all over India, in states and districts, so that they can be helping those persons to procure the PPE kit. Not only procuring, but equally essential. I think this is a good platform where I can say that wearing the PPE kit appropriately is equally important. Because we have seen that single training of how to wear a PPE kit and what all precaution needs to be done, when people try to reuse it, especially the paramedic staff, because they are equally important for us, we need to retrain them every time. We need to have a buddy check for them, so that they wear the kits very, very properly. So the teaching and training aspect is also being supported by the ISA and other healthcare organizations. So that's equally essential. The third aspect, which was being discussed about the elective cases versus emergency cases, ISA feels that the elective cases as of now should be deferred for some time, but the oncology cases and emergency cases should be ongoing. Now, there is a recent addition, it was being discussed today, that whether the RT-PCR should become the routine testing prior to a surgical procedure, even if it is, say, oncosurgical procedures, or it is for other emergency surgery procedures. I think that appears to quite plausible at this moment of time because the asymptomatic patients are quite in good number. With our experience here at this center, if we see that almost 30 to 40% patients will be almost asymptomatic. They will be having just mild grade fever of 98, 99, no other symptoms, but they will be RT-PCR positive. So looking at this population, which is asymptomatic, so should we go ahead and do RT-PCR for all patients before the surgical procedure, even if it's an emergency, because it can be done easily? The second aspect would be that India is procuring the antibody kits, which may be available within next day or two. So that could also be a screening tool for testing these patients, whether they are in acute phase of COVID-19 infections or they are in recovering phase. So I think these two tools needs to be considered with various organization and hospital, that how can we incorporate into our routine investigation modality so that cross-contamination across patients and healthcare worker would be prevented.
Yeah, and also,
in this regard, Dr. Rakesh, I just have to intervene. Should we proceed with all the cases with PPEs just like that? Because right now our cases are only 10,000 plus. How long we are going to postpone these cases? Dr. Bergese's point we can understand because they are cancelling all the elective cases because there's a huge surge in the New York City. But in India, how long we can postpone elective cases? Is it so many cases are in the waiting list? They have been waiting even for semi-urgent surgeries. So how long to wait? If you do the test, just do the PP and do the case. Is that as simple as that, or there is a huge consequence of that? Because at the later time, if surge comes, then we may our ventilator beds may not be available for those patients who are in distress or in the disease. So some consultants are of the field that what is there? We just do the PP, we just don the PP and do the case. So what's the big deal about that? So is that as simple as that, or there are a lot of consequences with that?
Sir,
to location
right.
as well as to Bergese, this question. Yeah.
Right. So I'll suggest my experience and whatever is being discussed in various scientific organizations. The one aspect is on a personal basis, on a personal experience at this center, any patient who requires an extended duration of hospital stay or an extended ICU requirement, probably those patients should be deferred for some time and they can be taken subsequently. But those patients who require some emergency surgeries, maybe when we talk of cancer surgeries, and they can be discharged in a day or two, depending upon the comorbidities and the type of surgical procedure, probably those can be taken at this point of time. But having said that, we should be very careful that the number of cases surge can happen at any moment of time. So preparation is the key. We have to evacuate the places. We have to evacuate the ward. The ICU should be evacuated immediately. So we have to think of, we have to have a plan that how can we evacuate in case the number of patients immediately surges. And that should be based on individual basis. Now, I was looking after the number of cases which are happening across different states of India. So that's again another interesting point. The lockdown is going a little success in India right now. If we see across states, the lockdown effect is variable in different states. Some of the states are working very well with the lockdown system. And the number of cases, the doubling time of the COVID-19 cases are coming down, like in Kerala. But in some of the states, the number of cases, maybe the hotspots are coming up and the number of cases are increasing to a huge margin, like in Maharashtra. So this means even the state has to take a call that this probably state is having good control over the lockdown and the other preventive measures. So they can take a decision that this hospital may run the normal routine cases and this hospital should be a COVID center. But those states wherein the number of cases, the doubling time is 2 to 3 days, we have to be careful. We have to have preparation so that we can get a place to admit the patient, not in a hurry to discharge the previously operated patient, but to get the space. Now, the second point is, as I mentioned, the asymptomatic patients are too much. So in those states where the number of patients are too high, should we include the RT-PCR as a routine investigation to take care of the healthcare workers? Because if somebody's gets an exposed to a person who is RT-PCR positive but was asymptomatic, we need to have a quarantine for that particular patient, for that particular team of the doctors and the paramedical staffs. We cannot lose the healthcare workers for quarantine even at this moment of time, because we have to be prepared ourselves. So that needs to be, I think, emphasized on organizational basis, because I'm aware of one or two hospitals where they have already ensured that all patients will be getting an RT-PCR done a day prior. But there is always a window period for the RT-PCR to come positive. It is not 100% specific. So we have to use PPE kit even in those patients. So I think what ISA advisory also says, that all patients should be considered as COVID suspect or COVID positive, and all precautions should be taken for management of these patients.
Dr. Bergese, what is your advice for our Indian anesthesiologists at this point of time? When our surgeons post cases, or when they ask us when I can post an elective case, what should we tell them? Because our cases are just 10,000 plus.
I think Rakesh said it really well. So 2-3 things is, number one is, if you're going to do elective cases, some of your anesthesiologists, some of your practitioners are going to get exposed and they're going to get sick. So they got to remember that. Second, he said the wave is coming really quickly, and sometimes it's so unpredictable. And I agree with. So we went from 0 to 500 patients overnight, and out of the sudden you get 100 patients in the ICU and the ventilator. So you got to be ready for that. And finally, is people are going to get very tired. So you don't want your soldiers to be tired when you need it the most. So you got to be you got to put caution on this and wait and see. I think Rakesh say really well is that you got to follow the numbers well. So if you're going to do this elective surgery, you got to be sure what you're getting into, when you may need your forces. Again, here it was one of the things that here was done well is that was predicted really well. We knew 2-3 weeks ahead, what are we going to get into? So we're going to get X amount, and exactly that's what happened. And now we level, and now the number, this is the first week where we have less patients in the ICU, and so on and so forth. And I don't know how good the data is in India, because I'm not there, so you guys know this better. So number one is, be sure that the data you're getting is truthful, be sure that it is reliable, and again, that way, then you can be prepared. So basically, to answer your question is, I will only do those cases if I know what I'm getting into, and if I can predict what is going to happen. So I think that's the only thing that I can tell you. Okay.
And Dr. Bergese, finally to you, what is your some techniques and tips what you do in routinely doing these emergency or elective cases which you take for operation theater? Do you use a separate intubation room? What kind of aerosol prevention procedures you use? And then video laryngoscopy is a routine for all the patients. So some tips and tricks for our practicing anesthesiologists here. What you're doing there? Yeah.
Right. So basically, we divide them in unknown patients and then the PUI or the positive patient. The positive patients and the PUIs, you got to treat those patients like they are sick. And what you do is, if you have an intubation team, you can use the intubation team to do that. That way, they are already dressed. I already addressed that. And you do it in a negative flow room. So that way, you do intubation and extubation in a negative flow room, and then you move those patients. For the other patients that are not suspected to be sick, you just follow the recommendations of, double glove, gown, eye protection, N95, surgical mask on top of that, and video laryngoscope, if possible, just to keep as much more distance from the patient as you can. I mean, that's basically it.
Are you using any covering sheet, a transparent sheet to cover the patient to prevent
We did
all
it.
those drops are coming?
Yeah, we did it. I mean, there's a lot of stuff out there. Some people put in plastic bags. Some people put in acrylic boxes or glass boxes with holes to put the arms through. You know, I don't know what to tell you. All those things are being unproved. I would say if you're dressed properly, I think that would be sufficient with the data that we have at this point. I'm not sure. This is my concern. The people sometimes, put those boxes, and then it's more difficult to intubate, and then they deoxygenate, and then you got to get the case out, and so I think control situation, pre-oxygenate for 5 minutes, give it a big dose of paralytic, do a video laryngoscope technique. I mean, I think it does the recommended steps at this point. Going above and beyond that, be careful, because not everything else that looks to be better sometimes is not. And my concern would be that then you get into, at this point, it's not needed, I would say, or not recommended.
Okay.
Yeah,
Thank you, Dr. Bergese.
I want to ask
for
hello. Phone.
One second, Manish, do you have a question?
Dr. Bergese
Yes.
in the beginning said one thing, that the hospital capacity was increased at this place. So that I just want to know how did they increase the total capacity of the hospital? How did they put extra bed inside the hospital and provide all other provisions? This is
right. So the surgery center was closed, and we put bed in the surgery center. PACU was closed, and we put bed in PACU. And then in some hospital, they put tents outside of the hospital, military tents. In some places, they use the stadium. So we have the stadium, ready to be put bed. And then there's a hotel really close to the hospital, and that was the next step. We were going to take that hotel, so to speak, and put beds in that hotel for less critical care patients. So you have a plan to expand little by little, and hotels is a really good way to do it, because people shouldn't be traveling at this point. So see, if there's a hotel nearby, you can build a hospital, so to speak, and places like that.
But how could you get healthcare workers? So many healthcare workers.
Well, you can't. So what you do is you redeploy. So the residents, they can practice on their own. Some of the nurses can practice on their own, supervise. You recreate a different system. So you get one ICU person directing people that there are not an ICU, and so on. So here in New York, also there were 90,000 people who were retired or they're not practicing anymore. They re-sign up to be helping out. So you do what you can.
Okay. Dr. Bergese, thank you so much for coming to our show and giving us some practical tips on how to approach this scenario. I thank you so much for taking up your time and a short notice come join our team for this discussion. Thank you, Dr. Bergese.
Oh, it's my
always a pleasure.
You guys always really, you guys really good to me always. So when you told me yesterday, I just couldn't say no. And again, I think this was much better than I imagined. So thank you very much.
Thank you so much. See you. Bye.
All right, bye-bye.
So that was Dr. Sergio Bergese with us. Now, when it comes to the Indian scenario, there are certain things which we need to take care of. Like you said, acrylic box or a plastic paper should not instill a false sense of security. The most important thing is that we should not lose the airway, and we need to take proper PP precautions. And there were a lot of questions which were shooting up, because in India, really, we don't have a proper negative pressure operation room theaters. There are theaters even which does not have laminar flow. Should we do in cases in these scenarios? So these are the questions which are cropping up. Dr. Anil Sharma, you work in a big institute, but Dr. Rakesh, the ISA has formulated the guidelines. So the working environment and the standards are not uniform throughout India. So how to approach this scenario? First, I'll go to Dr. Anil, then I'll come to Dr. Rakesh for this discussion. Dr. Anil, your mic, please.
Right. We see a whole spectrum of healthcare providers in India. So, right from the basic 20-bedded nursing home to, say, big corporates. Personally, in my hospital, I think what we are doing is taking consent. There is a separate COVID consent wherein it is clearly told that this is a pandemic period. You can give it to me and I can give it to you. Knowing this fully well, you are subjecting your patient to this surgery, and the hospital will not be liable for anything that happens, because we don't know what is the stage in which your patient at present is. Having said that, as recent as of today, there are certain guidelines being formulated wherein the COVID test will be made mandatory, and there is a discussion going on about adding CT chest or X-ray chest as another factor to screen much more patients which are coming. Then again, the debate here is whether, even if they are counted as negative, whether they should be kept as suspect and then treated accordingly, and what should be the level of PPE to be provided to the staff, because it's a definitive administrative concern to balance the cost of providing healthcare with the quality of healthcare to preserve the resources, which is the healthcare worker himself. So we should not go the way Italy and Spain went, like 10 to 15% of their healthcare worker was out of action in the first 10 days of the surge, and consequent to that, the mortality levels are very high. So what I will tell my friends who are practicing in the remote centers, that go to your IMAs. They are making available the PPEs. A basic mandatory PPE, I feel, should be like, you should have an impermeable gown, you should have shoe covers, you should have an N95, you should have a face shield, and then you can say that, yes, I am ready to approach my patient. So this is what, Ponniah, I can add from my side. Anything else you want to know?
Okay, I'll go to Dr. Rakesh. Dr. Rakesh, about this,
Yeah.
when the
Yeah.
system is not uniform, so how to approach this? Practical
Right.
tips and what does ISA decides on that? Yeah.
So I'll put 2 points important here. If you see the Indian scenario, the type of infrastructure and the facilities are very variable across hospitals. There are hospitals which are tertiary care centers and they have all facilities, and we have centers where the facilities may not be so good. So the first aspect would be that we need to prepare ourselves. So each hospital or each center should have a standby model or standby protocol, that if a COVID positive patient comes, how to manage it. So that type of preparation along with teaching and training must be there. And ISA is supporting for the teaching training and how to procure these at various district level and state level. So I think the ISA can be roped in through the state branches and district branches, so that the teaching training and the preparation part would be helped from the concerned person who are already trained into it. The second aspect is each hospital should have some working protocols with them. They need to identify an area in the hospital that would be suitable for management of COVID. So when we started our center at this place for converting an onco center into a COVID center, we had some definite technical issues, because no center is made for COVID patients, and COVID patients' requirement are a little different, because the unilateral movement of the person, the equipments, and the healthcare workers is very, very important, because we cannot cross contaminate each other. So what we need to do is, the same building, the same ward or same ICU needs to be segregated into places for movement of the contaminated persons and the clean area from the same place. So we need to identify those infrastructure changes. We need to we had to arrange these separate partitions of wood. We need to create a separate area. We need to barricade it. So what we did is, a segregated area for the movement of a patient who is COVID suspect and positive was ensured. So all patients and the patient and the healthcare worker who are taking care of them will only move in those areas. So once the care has been taken up and the person, the healthcare worker, is going off duty, he has to follow a different area path, so that he do not comes into that contaminated area again, and and he takes a bath, doff off, takes a bath, and go away. So that preparation of the infrastructure needs to be ensured. So this is very, very important. We need to understand, because we cannot cross-contaminate. A person in PP kit is okay, that he is getting protected. But if he moves into an area which is a clean area, the other person may get contaminated, because we are talking of level 1, level 2, and level 3 types of protective equipments for these patients, for the healthcare workers. So we need to give protection to our fellow colleagues also. This is one. Second thing is, as we are discussing about the intubation, the management of airway, the management of anesthesia, the ICU care, even in ICU, to my knowledge, when we are discussing with some of my colleagues at Singapore and other places, they require proning of these patients, the intensive monitoring. So the preparation plan, they are very varied. We have acrylic sheet, we have acrylic boxes with them. I am using acrylic box, we find it useful. But don't use them for the first time critically ill patients who require crash intubation. So it would be a good idea that at the part of training, I have kept one acrylic box in the conference room, in the seminar room. People can come, they can practice once, and then they can go, if required, they can intubate it. So that teaching and training session of various procedures that are desirable for management of a COVID patient is equally essential. The third aspect would be management of a patient in a non-COVID area. For example, the person who comes with emergency cases has happened in some of the hospitals in India also, wherein the history was not given by the patient to the hospital staff, and later on, when the patient deteriorated, they become COVID positive, and the whole staff, almost 30-40 people, were quarantined. So we have to be careful. So at this point, the suggestion would be, consider all patients at least COVID suspect. So if we can send investigation, fine. We can have a institutional protocol for it, if possible, RT-PCR or the antibody kits, which are very soon will be into the market in next a day or two. They can be used as screening tool for managing these patients. So you have to ensure whether this patient is COVID positive or COVID negative. If that surety cannot be done because of the lack of RT-PCR and other things, you should consider that patient as COVID positive and take all precautions, including the PPE kit, whether it's a regional or obstetric case.
Okay, you said antibody test.
I'm sorry.
About
your mic
test.
is
Hello. Yeah.
So
Rakesh, when we come to that, it's not only about PPs, it's also about engineering controls, your negative pressure rooms, laminar flows, and things like that. But in India, there are theaters where we don't have even laminar flows. So what is your recommendation for them? Should they do the cases in those theaters, or avoid doing cases at all in those theaters where the engineering controls are not good? Even in the recovery areas, or even in the hospitals where you don't have good engineering controls, because that is as important. The air exchange is as important as using a PPE.
If you see, there is very less number of ideal wards or operation theater or ICU that is suitable for COVID patients. So we require a negative pressure area, which will be very well suitable. But we do not have those areas across hospital. There are very few centers which have negative pressure areas. The laminar flow is again a luxury. It's not at many places. But the point is, we have to modify it to the maximum possible so that the healthcare worker and other ancillary staff are not getting infected. So we can switch off the laminar flows. We can increase the air exchange into it. We can use the HEPA filter. Somebody was discussing with me, if we can have some like AHUs can be fixed up with UV to disinfect the outgoing air. So that could be another option. So this means at this point of time, the engineering section has to be in liaison with the clinical team, so that whatever the best can be done should be done for these patients. We need to stop the positive pressure. We need to stop the laminar flows here. We can if we can increase the air exchange in these places where we are settling those patients. So having said that, this means we cannot convert the whole building. So the better idea would be, we select a place inside the hospital that can be converted into a COVID area center. So there may be some operation theaters, like transplant operation theaters usually have the best facility. So that can be converted into a dedicated OT or a dedicated ICU for such patients. And obviously we are deferring the elective cases as of now. So we can pool the resources and get those cases done at this point of time.
Dr. Manish, you had a point here.
I was mentioning one thing: the antibody test becomes positive at a later stage, so that I don't think that they can be useful in the, because we are more concerned about the patients who are asymptomatic, or maybe in the initial stage of the disease, when they might be asymptomatic or even mildly symptomatic, and they may transmit. So antibody test will not be positive at this point of time. So isn't PCR more reliable than antibody at this stage?
Oh, Dr. Rakesh, can you unmute your mic, Dr. Rakesh?
Sir, the point here is the antibody test will be only as a screening tool for here. I absolutely right. Even the RT-PCR and the antibody test have a window period. Even RT-PCR may be falsely negative in the initial period of incubation, and same thing will happen with the antibody, which will be judging both aspects, the IgM and IgG. So it will be having a dual antibody, the kit which are coming. So IgM probably starts with around say 4 to 5 days and then peaks up, and IgG will come a little later. So having said that, obviously that window period should be very, very important for us because we may missing some cases here. So that's why I said these are the screening tool that we are using it. If a patient comes out to be positive, definitely the whole process in the perioperative care should be like a COVID patient. But also, I said that all patients should be considered as COVID positive in today's scenario, at least COVID suspect. So we need to take all precautions. So this was a discussion here that whether regional blocks or the patients where they are receiving the spinal block, should the PP kit should be worn. So I believe, and most of the other faculty also believe the same, that these patients, the care, the healthcare worker should be treating them as COVID positive because we are not investigating them to the fully. They may be in the incubation period, and try to use PPE kit even for these group of patients. So that should be very, very essential. The only rider would be that the level of PP kit may be little different. If a patient is asymptomatic, no history of travel, no history of contact with COVID positive patients, no history of visiting an area which is having an high zone or a cluster area for the COVID infections. In those areas, you can come down with the PPE kit, but ensure that the PPE kit is worn and you are taking the whole precaution.
Dr. Prasanna?
Yeah, I don't think we are going to escape either by doing RT-PCR. Beyond the RT-PCR also, 70% only is the sensitivity. So it is the in due point of time. I think there are going to be some quarantines, home quarantines. So it is how wisely you can shift your staff. You keep some people on the bench, let them come in when the other people go on. It all depends on how wisely you can maneuver and do at most the most essential surgeries which are required. Okay, if you feel he has some symptoms, then you can wait for a day. You can do some test and do. Even if we talk of antibody kit many times, I don't think we are going to have so many kits which are going to cater all Indian population. That is not going to come anytime soon. So we need to have a plan. I don't know really how it is going to work out because we have a lot of pressure to start the elective cases, at least semi-emergency procedures. So if you go strictly by saying that all the onco surgeries are emergency and we should be done, nearly 60% of our surgeries routinely what we do are oncologic emergencies, and nearly 70 to 80% are tumors in neurosurgical patients. So that means that you are running a elective OT simultaneously, almost a elective OT, or you can say essential surgery OT. And in that you imagine in a, if the all the OTs are separate complexes, then you still better. But you are in a single complex with a 10 OTs, and one of the patient becomes positive, whole the staff of that complex has to go because there is a common AC and the common flow. So then you just imagine 200 of your staff going out of that. That is the issue. So how we are going to go about? Maybe Dr. Anil Sharma can take this question.
Yeah, actually, this we say near miss, like in it's in aviation industry, they say near miss. So these near misses are occurring, and Wokhart, if I want to name, Wokhart is one example. Many others, Delhi Cancer Institute, where apparently asymptomatic patients coming for very simple procedures tested positive, say after 7 days and 10 days, and the caregivers have to be quarantined to that extent that the whole campus was sealed and they were not allowed to go outside. So are we ready? Are we ready to pay that price in the very early days when we are not even getting the patients? Is the risk versus healthcare workers' safety? Like Dr. Prasanna rightly pointed out, like what is the way to go? The way to go is to isolate, to treat, as Dr. Rakesh rightly said, to treat everyone as suspect COVID or COVID positive until proved otherwise, and take care of each and every healthcare worker. Because if we go by Dr. Sergio's words, that suppose we get 1 lakh patients like the New York got, then the COVID positive asymptomatic anesthetist has to be there doing his duty. Mind it. That was a very big statement coming from him. When the things go to that level, then it's not about the COVID positiveness of the patient that matters. Even if the COVID positive doctor is there, he also has to be in the field. So we should not touch wood come to that level. We should screen. We should wear proper PPE. That is the message I want to give.
And Dr. Anil Parakh has a
Yeah,
point.
I
Yeah.
just wanted to add, there are a lot of literature coming the HRCT as a routine. So in our hospital, in most of the patients who are coming, we are doing HRCT test. One of the small bachu who was having fracture, we found if HRCT there was some consolidation, though he was mild cough and cold and some bronchi. And then we did the COVID test. We postponed the surgery for a day or so, and then we did COVID test. It was negative. Then we treated that bachu for antibiotic for this was a fracture radius ulna. So we did, it was not a life saving, but just wanted to tell you with the other some cases an HRCT if you can do is a better way than the routine X-ray in as a screening test. And even the COVID, if when you are doing, it takes long time. It takes around 12 hours in our hospital to get a report. So if you can, if in an emergency, we take due precaution, but at the same time, we do routine screening of HRCT and go ahead with the surgery.
Dr. Prasanna. Yeah.
Yeah, my fear here is that we are presuming all patients are COVID and we want to use the PP and mask. We do it, but we are in a still early part of the disease. We have not reached the level of Spain, Italy, or US. I hope we will not reach that stage. But it is always expected that there is a second wave of surge will be there when the lockdowns are eased out. Okay, so if you end up using all the PPs now, what stock you have available? We may both saying that we have around 10,000 PPs right now in our institute, but once the 10 patients go on ventilator, whatever the number of PPs are there, they are going to get exhausted. So when we ease the lockdown, we need to have a plan how we are going to go about that, how we are going to start our electives also. If everybody is very eager to start the electives, the moment you start and there is a second wave of surge of the cases, then we are left with nothing than to work without PPE. We need to be very careful when we are planning those cases.
Okay, so I'll get final comments from everybody. Dr. Manish, what next?
The important thing is preparedness, because as Dr. Bergese said, because I also asked him the same question, what his opinion, that what is a piece of advice that he can give to us, because he is the New York is seeing as a big peak and surge, and we are still in very initial stage. But it can be anticipated or expected that once the lockdown is over, we will see a surge. I don't know how we should treat the patients at this point of time when the prevalence is very low, when very few patients with COVID positivity are coming. I don't know that whether we should use all the full-fledged PPE for all the patients, or we should be a little bit judicial in using them so that we can save them for future. I'm not myself very sure, but it also depends upon the availability. Like my hospital, they have made a policy that they will test all the patients, all the surgical patients before the surgery. And even today, there is a circular that it is possible that they might be testing all the staff and all the patients who are admitted for COVID. So it is a hospital policy. It depends upon what hospital is planning. We are allowed
So,
to use PPE when we find it useful, or when we find that it is essential to use. We can use PPE. They will provide us. So, as my hospital is generous, I can use them generously, or I may apply my own thought of how to use it. But
okay.
at many places, there is a scarcity or there is a rationing of PPEs. So at those places, they have to be more careful, because they should use when they need it mostly. So
Okay.
that is what I can tell at this point of time.
Okay. Dr. Anil Sharma, your final comments on what next, how we should be prepared, and what are the things we need to do?
See, my personal thing, and when I talk to my fellow colleagues and my other friends who are in different parts of India, the fear of contracting COVID amongst the healthcare worker is very real. Another point, they are very like afraid to get their families infected if they go back home. So I take this from Dr. Sergio when he said when the cases will improve, the cases will increase, you will be more comfortable moving around and handling these cases. I think this is the key. So when the cases improve, your safety level will go up, your alertness will go up, and you will be more comfortable moving around when there will be more patients. So I think this will kick in, and we should be prepared for that day.
Okay. Dr. Anil Parakh, sir, what next, and how are you planning to manage when this lockdown is coming to an end? Yeah.
No, I fully agree. So we have to take care according to the zones. I think the people, particular red area zones, like Mumbai, which is the high alert, particularly, and there's a surge of the positive patients. We have to be very careful. You cannot take risk in public. In 5 hospitals in Bombay has been shut down, and a lot of health workers. So learning the lesson from these, we have to take precautions, particularly in an institute where you can afford it. I'm not saying, and particularly if you cannot afford, don't unnecessarily do the venture of doing the surgeries. So refer that center to a bigger center where you have the facilities, and don't unnecessarily expose yourself. So you can be prepared for the next thing. That's my thinking.
Okay. Dr. Prasanna, your final comments on this. What next?
Yeah, as of now, we have gone for a pan-India protocols and pan-India lockdown. As the lockdown finishes, we need to go for a regionally, say at least a state-wise where it is going to have. Then we need to have protocols for each state separately. So as the governments do it, we as anesthesiologists also have to do it and migrate the resources from the other less affected states or where the curve is coming down, the resources to the state where it is required more. We need more cooperation between the states as we progress into the releasing of the lockdown in maybe another 20-25 days.
Okay. Dr. Rakesh, your final things and how we are going to shape up the near future.
Sure. Yeah. I'll put 2 points here which are important. One is the prevention, the other is the preparation. Now, preparation is definitely good. We need to now take a lead into creating an healthy environment for people around her to understand the preventive strategies because we do not want to see the surge. We want to prevent it. So I think from Pan India people, the anesthesiologists can take a lead that they can have some positive messages in their groups so that people understand the principles of lockdown, hand hygiene, tough etiquettes, self-reporting, which is again very important. So this is one important aspect. And the second important aspect will be preparation. So we have discussed majority aspect, but what I need to put the point here is the preparation should be adequate teaching and training, not teaching and training when the actual patient comes. Less teaching and training, let's do a drill here, let's practice on the mannequin and understand that if actual patient comes, how this happens. The other important aspect of preparation will be, which we are doing at our centers and other places also, the pooling of the resources, the human resources. For the first time, my team has people, the faculty and the residents from across the department. So with me, people are from pediatrics, people are from medicine, people are from surgery, people are from pediatric surgeries, and we are creating a wonderful team. For the first time, we are working in this team, managing the same patient, but with different strategies. So each hospital, each organization should have resources of pool so that we are not constrained when actual situation forbid if it comes, we are able to manage it. So that pooling of human resources with teaching and training should be an important aspect of the preparation as of now.
All right. So your final point, yeah.
No, a lot of people who are watching the show are more concerned whether aerosol generation is more doing intubation or extubation. How are we going to plan the extubation? Maybe Anil Sharma or Rakesh can take the question.
Yeah,
How
Rakesh.
we yeah, Rakesh can also add to it. How we are doing it in our setup is that, and I learned it from one of my friends in Liverpool. Like we are asking rest of the staff to leave the theater if they're surgical staff, the scrub nurse, and all that, right? And then we extubate the patient. Personally, I tend to extubate the patient on spontaneous a bit deep so that the cuff reflex is prevented, and do the suctioning when the airway is secured, so that the aerosol is minimized. And then we wait for another 20 minutes, right, before anyone comes in again, so that the aerosol settles. So this saves our rest of the staff from the exposure. This is how I am doing it. Dr. Rakesh can add to it.
Perfectly fine. Is it possible to share one slide here, or should I just speak verbally?
Okay, you can share one slide.
It is better you just tell the answer.
Okay, right. So what I mean is when we say for the airway management, the whole process is important. Intubation as well as extubation, both are very important. And Dr. Sharma has already put very rightly that we have to wear the proper PPE kit. Now, there are various innovations which are coming. Dr. Sergio Bergese was also discussing among them. Now, use a technique which you know the best, but at this point of time, comfortable technique would be using a video laryngoscope and covering the area nicely so that you are not creating a lot of resources. Even at this point of time, I will emphasize that the person who is well equipped, well trained for the airway management should be on the head end. So this is not the time for training on patients on COVID. So the senior most person, the well expert with the best of equipments, which is well trained with, should try to intubate those patients. And same precaution should be for the extubation part also. Just remember that giving a high flow oxygen can create a lot of aerosolization. So that needs to be avoided. The methods could be using a mask, tight fitting mask, covering it with a plastic sheet, covering with the acrylic sheet. All those methods are acceptable, but you should also realize that those patients who are COVID positive, they have less oxygen reserves, they have lung infiltrates. So the chances of air exchange may not be so good. So you need to balance both things. And that's why I said doing a good drill is equally important. So have a mannequin with us, put something over it and try to intubate. And same thing needs to be translated when actually you are managing these patients.
Okay, so we have come to the end of this session. So conclude that there is certain uncertainty of what's going to happen, but the most important key is preparedness. We have to be prepared because we have to deal with situation as and when it arises, and we have to carefully select the cases based on our practicing setup, resource availability, PP availability, and how we can able to handle complications when it happens. So this is the key. We should not land up in a situation where our whole unit gets quarantined and our hospital gets shut. That should be completely avoided. So with this, I thank all the speakers for coming to the show.
I just want to tell Ponniah, first of all, congratulations for this talk and all that. One response that I'm getting from many of my colleagues, anesthetists all across India, is that they want one more session where they can ask and we can answer. Just work on that.
Definitely. No, we will plan that, and definitely there are sessions. In fact, on Thursday we have a session on critical care management of COVID, and we are getting intensivists who are managing COVID patients from UK.
Right.
That will be on Thursday. So we'll be having sessions. On one session, we are planning on using all the what you call the jugards or the innovations, whatever you call that. We want to discuss one by one whether it is really helpful or just a hype. Okay, we are just compiling that. So we'll have discussion. We'll take questions from everybody. We'll share a link and take questions from everybody. Definitely, we will do that. Okay. Thank you so much, Dr. Anil Sharma, Dr. Rakesh, Dr. Manish, Prasanna, for coming to the show. So on Thursday, we will meet up with the critical care management of COVID patients. It's very important. So with this, I conclude this classroom. Thanks for watching. Thank you so much. Follow us at Neuro Classroom. Thank you.